Nilesh, you go to slideshow.
Yes, sir.
नहीं चालू है
सुनाई नहीं दे रहा है।
आएगा
Nilesh, are you ready to present or already started presenting?
No, sir. I'm waiting for confirmation.
Just because, so this is the actually second slide displaying here, not the first slide.
Yes, sir.
So
Just, I was just checking this thing.
So actually, the organizers they're asking to start the session. Please, Nilesh, can
Yes,
we
sir.
start? Can we go ahead? Vijayanand sir, can we go ahead?
Yes, sir. Yes, sir.
Just briefly, I will say this is a weekly session, 3-time session, and so well organized for last so many almost years for all DNB, DM, and other academic students, trainees, going very successfully. Today for this session, Rainbow Children Hospital first year DNB specialist, DRNB specialist first year student Dr. Nilesh Ranjan is going to present a challenging fetal case, and through his presentation he will guide us how the presentation causes challenge during the antenatal life or the dilemmas, how the preparedness and team preparedness helps in managing case well. And to the session to moderate, we invited today Dr. Vijayanand Jamalapuri, our neonatology consultant, who is an eminent teacher and a well-known person for the simulation in the country. And he is totally involved throughout from the antenatal counseling till the patient discharge. So probably he will be here to guide throughout the session and to moderate the session and guide us how the case management happened, what are the challenges, and how successfully the case is managed. The dilemmas and challenges and the team which wins, he will describe probably. He will supplement with Nilesh, Dr. Nilesh's presentation. So just with this, I will request Dr. Nilesh to start, and a few words Dr. Vijayanand can add whenever he thinks so. Thank you.
No, sir. You nicely introduced. It's one of the challenging cases of challenges at multiple levels. I think let's hear from Nilesh. So if the presentation is going, and I won't necessarily disturb, but at any time anybody wants to ask, clarify, please raise your hand. Me and Nilesh try to clarify the questions you may have. And if you want to discuss anything also, put in the chat box. We can take those at the end. And I won't necessarily disturb the Nilesh unless needed. Yeah, over to you, Nilesh.
Okay. Good evening, everybody. So today we'll be discussing this case. It's a case of antenatally detected fetal neck mass. We are presenting from Rainbow Children's Hospital, Hyderabad. So the circumstance here is we have a baby of a mother, a term mother, SSK. Is a term baby girl, and it's about the baby's birth weight is 2.5 kilos, and it is born to a mother who's G7 and A6. It's been delivered by lower segmental cesarean section, and indication for cesarean section here was a fetal neck mass which was compressing the airway. This was detected antenatally. So let us go into the antenatal history of this mother. So here we have a 33-year-old mother who is in a non-consanguineous marriage. This is her 7th pregnancy with previous 6 abortions within her 9 years of marriage. There was no history of any gestational diabetes, antepartum hemorrhage, pregnancy-induced hypertension, urinary tract infection, hypothyroidism, any premature rupture of membrane, or any fever during this time span. You can see on the screen that she has had multiple miscarriages before, and most of them were around 6 weeks. She had undergone a detailed evaluation, and then this was the current pregnancy, conceived in 2022. So antenatal history, the pregnancy was going on smooth until at 27 weeks of gestational age, this mother's ultrasonography detected polyhydramnios with a AFI of 35.9 centimeters, and also a fetal neck mass in the lateral aspect of the neck. And this mass was showing both solid and cystic components, which was extending anteriorly. This was followed by an MRI report, which we will discuss. For this, the mother underwent therapeutic amniocentesis about 3 times, and eventually an exit procedure was done. So we'll go into the ultrasound scans.
Nilesh,
Yes, sir. Yes, sir.
just a quick, this was a huge mass, as Nilesh will describe. So before they come to us, they have been to several institutes and clinicians, and this family was actually was told and discouraged to discontinue the pregnancy. You can understand, because of the without exit procedure, there is no hope. So, but this family wanted to give a chance no matter what it is. So they came to us and asked us, is there a hope? So that's where they just came to the outpatient with all these reports and asking whether something can be done. So that's how the journey with our institute has started. So over to you, Nilesh.
Yes, sir. So these are the ultrasound images of 27 weeks, which are showing a lateral neck mass. And in the follow-up scans also, this mass was increasing in size, after which an MRI was done at 32 weeks. So this is the axial and sagittal section of the MRI of the fetal neck, which was showing a large asymmetric multiseptate exophytic mass, which was well encapsulated, and it was solid appearing, and it was stick space occupying lesion in the subcutaneous plane from the left submandibular region all the way to the supraclavicular region, involving the deeper planes also. So the other view we can see is this is the other view where the compression is noted at the nasopharynx and prominent fluid in the oropharynx. These were consistent with multiseptated cystic masses, and there was no fat within, and there was no calcification detected at this stage. Polyhydramnios was obvious. There was no evidence of fetal hydrops, which was important for us. And the lungs were also showing normal signal intensity. There was no pulmonary hypoplasia, and both the diaphragms are also showing normal signal intensity. So at this stage, antenatally, there were 2 differentials that were in our mind. One was a possibility of giant cystic lymphangioma, and second was a teratoma. And it was more in favor of a giant cystic lymphangioma in view of the signal pattern and absence of any calcification in this. And T2 hyperintensity signals and T1 was isointense without fat. Post this, mother underwent therapeutic amniocentesis about 3 times, and eventually at term an exit procedure was planned on the day of delivery. So for an exit procedure, a multidisciplinary team was prepared, which consisted of a lot of key members here. So first of all, there were at least 2 to 3 obstetricians on site. Then the neonatologist was called to secure the airway and stabilization of the baby. we had called a pediatric surgeon, a pediatric surgeon for any surgical intervention, and for a pediatric otolaryngologist, the ENT surgeon also was available on site for possible bronchoscopy. Then the obstetric anesthesia team was there. The fetal medicine experts were there. A pediatric anesthesia team was also called for securing a difficult, in anticipation of a difficult airway, and the nursing staff was also available. Since this procedure had multidisciplinary intervention, requirement of multidisciplinary team, so we had to do a rehearsal and a whole layout of the operating theater as to who will stand where and how the intervention will be done was done multiple times. So twice at least this rehearsal was done prior to the planned exit procedure. So this is a picture showing a mock drill. Briefly, we'll go into the exit procedure. So exit procedure, and the alternate is a OOPS procedure, where is operation on placental support. In operation on placental support, the baby is still connected to the uteroplacenta is still connected while all the four limbs are out. Whereas in exit procedure, usually the head, neck, and one upper limb is delivered. So the exit procedure was first developed for reversing tracheal occlusion in cases of congenital diaphragmatic hernia to relieve the tracheal occlusion. And this exit procedure can be performed on vaginal deliveries as well as cesarean sections. So a portion of fetus here is delivered, and the brief procedures, whichever is planned for securing an airway, they can be performed while the fetus is still connected to the placenta. The most common indication for doing a exit procedure is to secure an airway in babies with large neck masses, as in this case, or cases of chaos, that is congenital higher airway obstruction syndromes. So types of exit procedures, we have an exit to airway procedure, where the aim is to evaluate and secure the airway during delivery in cases of chaos or in cases of congenital neck masses, as was our case. Then exit to resection procedure is also done. This involves partial or complete surgical removal of the neck mass in toto. Then exit to ECMO procedure is also done in severe non-compatible congenital heart anomalies, and exit to separation procedure in cases of Siamese twins. The basic principle of an exit procedure is to maintain a uteroplacental circulation by giving controlled uterine hypotonia. So the uterus has to be relaxed and not go into a state of contraction, because that will again hamper or it will interfere with the blood supply of the placental circulation. So this puts the mother, or it endangers the mother in view of postpartum hemorrhage after the delivery. So the exit procedure, it enables to secure your fetal airways and decompress or resect the large neck mass and provide vascular access in cases for ECMO. And the key here is achievement of tocolysis. And after the hysterotomy, the fetal head and neck and one of the arm is delivered, and the rest of the fetal body and the umbilical cords remain. So the principle here, and the thing is, the exit procedure, ideally, cephalic position of the baby is ideal. And if it is not in a cephalic position, then the hysterotomy incision that is given, it may have to be extended to achieve adequate exposure of the fetal head and neck. It requires deep maternal anesthesia without the induction of hypotension, and indirect fetal anesthesia is achieved without any cardiac depression. And this prolonged uterine relaxation is necessary here to achieve uteroplacental circulation. Now, since we are anticipating a large fetal neck mass, so this is an algorithm for managing a fetal airway in this kind of scenario. And our team had to go through all the steps post-delivery. So after undergoing a complete prenatal evaluation using ultrasound and MRI, we were anticipating an anterior neck mass, which was causing compression of the trachea. So we had planned an exit procedure. Post-exit, once the baby was out, the first option or the first step would be to visualize the larynx. So laryngeal visualization, either using a video laryngoscope or using a direct laryngoscope, whatever was available there. Second option would have been to suppose the visualization was difficult. In that situation, we would be using a fiber optic endotracheal intubation. using bronchoscopy. And third option here would have been if we are still not unable to visualize the airway. So in that situation, rigid bronchoscopy or a tracheostomy was planned. So so these are the this is the step-by-step plan that we had. So these were the essential instruments that we had prepared for this delivery. So a video laryngoscope.
Yeah, Nilesh, couple of
Yes, sir.
comments here.
Yes, sir.
So, to our knowledge, there is one reported exit from the CMC Vellore, and not many reported from India. And but some of the units in Western countries, it's a routine whenever the situation comes. So it is one of the unique procedure which we sort of did one baby, but not that meticulously planned in the previous case with lymph. Already showed to us how many people have been involved, and you could have seen in the pictures all the specialty people, and we had a discussion well before, not even a day before, the well before we had a meeting. So how to plan, whose job is what. And the other important thing is, one of the important thing here, what Nilesh mentioned, the requisite for the exit procedure was the cephalic presentation. So in this situation, in this baby, so actually the lie was slightly transverse. It wasn't completely favorable. So one of the discussions, the obstetricians were discussing, once the mother is induced to do a change of the fetal position, but luckily by the day it turned out to be a vertex on the table. But a lot of preparation was required, as Nilesh was nicely describing. Over to you, Nilesh.
Yes. So for the preparation, we had prepared a video laryngoscope with clean grades. We had a direct laryngoscope also. We had 3 and 3.5 1-cuff tubes with stillate, boogie, and ET plasters. Neonatal ambu, all sterilized. ETCO2 probe was also there in event of since it was difficult to visualize for confirmation. We had monitors with SpO2 probes and all clean. NG tubes, suction catheters, lignocaine jelly. All this was prepared well in advance. So you can see here, this is a very busy operating room with a lot of people from various specialties here. So in the operating room also, pre-operatively, amniocentesis was done under the anesthesia care, and ultrasound guided aspiration of the fetal neck cystic mass was done, and around 190 ml was aspirated here in the operating room just before the delivery. Ultrasound guided aspiration was done. Now, after confirmation of uterine relaxation, uterine incision was made. The fetus was delivered till the level of nipple. Umbilical pulsations were monitored by another obstetrician, and the amniotic fluid was leaking out. So this could have led to placental suppression. And as a preventive measure, normal saline was infused into the uterine cavity. So as was the plan for this difficult kind of an airway, we attempted using a video laryngoscope to secure the airway, which was unsuccessful. There was distorted anatomy here. So this is our neonatologist who's attempting a video laryngoscope, which we could not visualize. So now, as planned, we are going to the second step here, where an ENT surgeon was already there. He was trying to do a bronchoscopy, which was again unsuccessful. So this is the ENT surgeon and the pediatric surgeon also. Both of them in connection, they were doing the pediatric bronchoscopy. We also have the image of the bronchoscopy that was done. You can clearly see the mass indenting on the airway. So after the second attempt also, then our last resort was going for a tracheostomy. So airway, and this time we were lucky enough to secure the airway by tracheostomy, and the tracheostomy was again confirmed by the ETCO2 monitor. So this is the third attempt where a tracheostomy was done for to secure the airway.
So it is a plan C. So first attempt of the tracheostomy, but plan A, rigid bronchoscopy, and then video laryngoscopy or in the video laryngoscopy, rigid bronchoscopy, and tracheostomy, not the tracheostomy third. Yeah. So I'm just clarifying. Yeah.
Yeah. Yes. So until now, the baby is still connected to the placenta, and we have not delivered the baby yet. So it took almost about 10 minutes and 45 seconds to secure the airway from the time of uterine incision. So this is how we secured the post tracheostomy, how the airway was secured, and after this the baby was shifted to the NICU. So in the NICU, vitals just immediately after shifting to the NICU, the vitals were quite stable, and then you can clearly see how massive the neck mass was even after repeated aspiration. So immediately after shifting to the NICU, again assist aspiration was done, where 30 to 40 ml of the fluid was removed. After this is the first X-ray of the baby and the first blood gas, which was again showing respiratory acidosis. After this, again, the first day was quite stormy, and again, the progress, it went downhill here again. Baby was developing severe respiratory acidosis and increased FiO2 requirement, and also baby had hypotension. And this is one gas which was again showing severe respiratory acidosis. So at this time, bedside, this is at about 12 hours of life. So at this point of time, we were at bedside, we were doing our dope analysis, as in case of an intubated baby. So there was no displacement of the tube that was placed. Air entry was there. There was a possibility of pneumothorax, and the equipment was working just fine. So we did a bedside transillumination test of the chest while we were arranging for an X-ray. So this was the image of the transillumination. So definitely there was a pneumothorax, and later by the X-ray we have confirmed that there's definitely a pneumothorax. After this, an ICD was placed in the right side of the chest, and then the baby was oscillated. So the baby was put on high frequency oscillator, and for the hypotension we had to start on multiple inotropes. So these were the major events in the first 1.5 day, where the course was quite stormy. Second day, we were in a dilemma stage whether to operate the mass on the day 2 itself or wait for a while. But at this point, we were again a little anxious as to if this mass could again cause further occlusion, and what if the tracheostomy tube which was there could again be compressed by this. So eventually a decision was taken to go ahead for the excision of the mass. So post the day 2 of life, the surgical excision of the mass was done, and then the baby was again brought back to the shifted back to the NICU.
So Nilesh, yeah, you are absolutely
Yes,
right.
yes.
So there was a lot of initial plan was to leave him for a while until he gets stabilized, but actually his requirement was HFO was high, and it is a relatively suboptimal tracheostomy, and the pushing the tube other way around. So we thought removing the tube would help, and to do that we got HFO ready by our anesthetic team. Even the neonatologist was there, and Dr. Harish Jairam, who is our pediatric surgeon, with his team, and did a 4.5 hours, nearly 4 hours, and they could take out the mass in toto. Yeah. Over to you.
Yes. So post this again, baby had ventilator requirements. So baby was taken off HFO after 1 day, and on ventilator baby was extubated again on day 5. After this again, we had provided CPAP support and other non-invasive modes of ventilation. But during this, while also we had moments when the tube was blocked, requiring again changing back to mechanical ventilation. This happened on day 7 and 13. We also had done an ultrasound chest where the left dome of diaphragm was at higher level with paradoxical movements, where we were again suspecting whether there is any ventilation or there's a diaphragmatic palsy because of any probable phrenic injury. So these were the subsequent X-rays, the follow-up X-rays. Again, day 43 in this course of ventilation, baby had acute deterioration, where there was a total bradycardia, and the saturations were not recordable. At this time, bedside again, like going according to the dope algorithm, So there was the tube seemed to be fairly in position. There was no displacement of the tracheostomy tube, and there was no, on auscultation, there was no air entry at all. So there could have been a possible obstruction. Trans-elimination was negative. There was no pneumothorax. We done an X-ray also where there was no pneumothorax, and the equipment was working fine. So we were suspecting that the tracheostomy tube here was blocked. So eventually we had to remove this tracheostomy tube and again put the baby on conventional ventilator. This is at around 6 weeks of life. At this point of time, we were again stuck where like we have seen multiple X-rays where baby is consistently having a right upper lobe collapse. Baby was producing copious ET secretions. And another thing that will be discussed later was we also had a gastrostomy done for the baby because of swallowing dysfunction. So at this point of time, even after 6 weeks after delivery, we were still on conventional ventilator. So we had to do an airway assessment. A microlaryngoscopy was planned to evaluate how the airway, what was the status of the airway. So a microlaryngoscopy was done, and here, like the vocal cord movement was fairly okay. The airways were not collapsing. So you can see the vocal cords, the movement seems to be fairly okay, and the airway is not collapsing. Once we go a little deeper, so we can see the tracheostomy tube, which is sitting quite deep, and almost it is going into the from the main bronchus, it is almost going into the right bronchus. So upon withdrawal, you can see that.
Yeah, Nilesh, just a comment over here.
Yes, sir.
So before, so you might be wondering why tracheostomy tube was replaced by ET tube. The challenge was the tube we couldn't recalculate this. But before that, even at the gastrostomy, we know that this airway is better, and we know that we can intubate this baby in case of emergency. That's what exactly we did. And this tube was causing us a lot of problems, which I think you will be discussing in a minute. Yeah. Over to you. Yeah.
Yes. So in total, baby was on HFO support for 1 day, conventional ventilation, initial spell for 5 days, then 2 days, and again 3 days. CPAP support was also there. Non-invasive ventilation, CPAP was there for 6 days. Baby required non-invasive ventilation for 1 day, and high flow nasal cannula for 10 days. And until discharge, baby was on low flow. So so the tracheostomy tube that we have used in this case was a Bivona 3.5 size uncuffed tube with a straight neck flange. So a quick word on how to choose the tracheostomy tube. So this is a chart which is given by the Great Ormond Street Hospital, and we can see the tube that was used in this case was a 3.5 size tube, which Gauss recommends for 1 to 6 month old babies or infants. So this is just for reference. So a quick word on neonatal tracheostomy. So neonatal tracheostomy, the most common indication here is an upper airway obstruction because of structural airway abnormalities or craniofacial syndromes. And in babies with chronic lung disease and those with need for prolonged ventilation, 45%. And 5% of babies who require endotracheal suctioning, as in those with neuromuscular weaknesses and paralytic illnesses. So here, possible problems could have been a tracheostomy occlusion, and occlusion again can be early when it is done before the first tracheostomy tube change, which usually happens at around 5th to 7th day, or a late tracheostomy occlusion. And occlusion, most probably it happens because of pulling up of secretions, or sometimes due to formation of a granuloma, it can happen, or sometimes because of the tracheostomy going into a false tract. So another anticipated complication here could be an accidental decannulation. And early decannulation again happens within the first 7 days. In such a situation, you can just put traction on the stray sutures, expose the trachea, and recannulate. And this can be again confirmed by either an endoscope later or by using a simple suction catheter, a flexible suction catheter. If it is going beyond your tracheostomy tube and not just till the end of the tracheostomy tube, it is likely that it is in the right tract and not in the false tract. Late decannulation, it is better to prevent late decannulation by using a tracheostomy tie and giving and giving cervical traction. And another way to prevent, yes.
Nilesh, one of the challenge with this tracheostomy tube was it was on the lower and towards right, and as you nicely showed in the bronchoscopy, it was touching the right main bronchus and irritating the baby. So what we were trying to do, we were trying to elevate it with the gas, and it was coming too out, and we were trying to put in, it was going too low. So it was relatively suboptimal. Bear in mind, but this is the tracheostomy tube which saved the baby's life or given the life to the baby in the postnatal life, and but wasn't helping at this stage. So that's why the accidental decannulation happened, because we were trying to balance, keep it in the not too low or not too high. That was the reason why it came out on the couple of occasions. Over to you.
Yes. So one anticipated frequent problem with routine tracheostomy is pooling of mucus, which can be prevented to some extent, because here we are bypassing the nose and the oral cavity, and we are totally losing upon filtration, humidification. So we have heat and moisture exchanges, HMEs, and heated humidifiers that can be used to prevent this mucus plugging. Cardiac evaluation is also done in order to rule out other associated cardiac anomalies, and also to rule out if any pulmonary hypertension was there. And on day 2 of life it was done, and serial echoes were also done, which showed normal cardiac functioning. This baby was off inotropic support by day 3 of life. Gastrointestinal wise, this baby was started on NG tube feeding initially, but later on we could not achieve pallidi feeding. Probably baby had oropharyngeal incoordination and this sucking swallowing incoordination, for which on day 25 a gastrostomy with fundoplication was done. And post procedure, this baby was tolerating gastrostomy tube feeds well, and post discharge actually baby was gaining weight. Neurological assessment, the neurosonograms that were done were normal, and the baby's neurological behavior also seemed to be fine. But what we noticed was there was lower motor neuron type of facial nerve paralysis. Sepsis wise, like this baby was in the hospital for about 2.5 months, and there were multiple episodes. There were multiple episodes of deterioration, and always septic workup was done, but never the blood cultures grew anything. Baby required multiple multiple transfusions of various blood products, LRBC transfusions, platelet transfusions, and FFP transfusions. Earlier we had mentioned that at around day 40 around, that is 5th and 6th week of life, baby was having, we were stuck on the ventilator, and baby was having copious oral secretions. So twice the ET secretion culture had grown. Had grown a positive growth. Once it was Klebsiella pneumonia and Acinetobacter baumannii. Appropriate antibiotics were given parenterally, as well as inhalational antibiotics were given. So this is just the various lab parameters, the serial monitoring of various lab parameters. Initially, there was no evidence of any malignancy as such. The counts were normal. And later on, day 2, day 5, and up to 2nd week of life, baby required multiple platelet transfusions and blood transfusions post-surgery also. Baby had coagulopathy, initially required multiple FFP and cryoprecipitate transfusions. The mass that was resected, this was sent for histopathology and the entire histopathological analysis. And it was found to have multiple cystic spaces with variable epithelial lining of squamous ciliated columnar goblet cells. And there was presence of cartilage and adipose and glial tissue. So, and these immature elements were occupying less than 1 low power field. So the final diagnosis given was a grade 1 immature teratoma, which is most likely benign. So this is just the slide, and the pointer here is showing towards the immature neuroglial elements, which makes it an immature teratoma. Had there been more of mesenchyme, then it would have gone into diagnosis of a mature teratoma. So here, the tumor marker surveillance that we had done was the beta SAG, which was done, was normal. The alpha fetoprotein was elevated initially, but on serial follow-up, it was showing a falling trend. A brief word on cervical teratoma. These are rare benign tumors in neonates and they comprise about 3 to 5%. And the incidence of cervical neck teratoma is 1 in 20,000 to 40,000 births. And they contain immature tissue, which we had seen in the biopsy. And we all know that teratomas are derived from all the three germ layers, the endoderm, ectoderm, and mesoderm. Associated malformation with cervical teratoma could be an imperforate anus or a hypoplastic left heart syndrome. We had done an echo here, which was normal. And neurologically, there can be an absence of corpus callosum or presence of an arachnoid cyst. We had done serial neurosonograms, and the baby's neurological behavior is also normal, so we didn't intervene. Cervical teratoma, teratomas in general, the most common location in neonates is the sacrococcygeal location, followed by gonadal location. And cervical is the third most common location where teratomas are seen. Diagnosis preoperatively, imaging can be done, ultrasound, CT, and MRI. Actually, CT is the best mode of visualization here. Presence of multiple calcified foci on radiographic imaging is highly consistent with diagnosis of teratoma. And preoperatively, a thyroid function test should also be done, because in the presence of a cervical neck teratoma, there is high chance that the thyroid tissue is also present in this. It could be present in this, and post excision, there may not be a thyroid gland. The differentials here could be a lymphatic malformation like a lymphangioma. It could be a congenital goiter, an arteriovenous malformation, or a branchial cleft or cyst. Antenatally, we had lymphangioma as a close differential in this case. Differentiating between lymphangioma and teratoma, lymphangiomas are all fluid-filled cystic spaces divided by fine septae and located usually in the anterior and posterior triangle of neck. Whereas the teratomas, they're usually asymmetrical, unilateral. In this case, it was unilaterally towards the lateral side of the neck, and showing multiloculations with solid and cystic component. So this combination of solid cystic component with calcification will clinch your diagnosis. But unfortunately, in our case, in the antenatal MRI, there was no calcification detected. So teratomas are classified by using the Gonzalez-Kruse grading system, where 0 is the mature or benign one. 1 is immature, which is probably benign, which was our case. Grade 2 or immature, which is possibly malignant, and grade 3, which is frankly malignant. So the treatment of cervical teratoma, that to an immature, would be a complete surgical excision. And if it turns out to be malignant grade 3, then chemotherapy or radiotherapy. The prognosis, the long-term prognosis of cervical teratoma is good, and the recurrence rates are quite low. Post-operative surveillance of teratoma should include alpha-fetoprotein levels at 3 monthly intervals in infancy and up to at least 3 years of life. And MRI scan for at least once a year for the first 3 years of life has been suggested. So eventually, after a long stay in the hospital, so this baby was discharged on day 84 of life with a weight of 2.77 kgs, birth weight being 2.5 kgs. It was discharged on discharge hormone, low flow oxygen, and these were the final X-rays, vitals, and blood gases. We've had a long follow-up of this baby. This is the baby's image at 6 months of age. Neurologically also, the baby seems to be doing fine, and the weight gain is also good. There's no tracheostomy now, and there's only a gastrostomy tube through which they're feeding.
Baby had dengue around 4 or 5 months of life, but recovered completely. And yeah, so now around 7 to 8 kilos. Now it is 7 to 8 months, Nilesh.
Yes.
And still the solids are started, and a lot of boromotor stimulation still required. Bear in mind, this is the esophagus which was compressed like anything entire fetal life, and there will be definitely some motility issues. So, but she started taking orally as well.
Yes.
Yeah. So I think there's a question. Do you want to take it, or shall I? Histopathology you already mentioned. Nalli sir? Nalli sir? So why gastrostomy is, as I was telling, as we were discussing, that this baby had a complete compression of esophagus and the trachea, and the esophagus would have definitely motility issues. And also because of this, because there was no fetal swallowing, because the learning happens in the fetal life itself. So that's why it took a while, and now it is improving. Eventually, the plan is by 1 year, but she's growing well. So hopefully by 1 year we should be able to close the gastrostomy, and where she would completely take everything by oral.
And antenatally also it had resulted in severe polyhydramnios.
Yeah, that again tells you that there was no fetal swallowing. That explains, as you remember, same with the esophageal atresia things, but the motility issues here was more of a functional rather than a physical and physical obstruction, because it's a physical obstruction but led to the functional derangement of the motility. Nalli sir? So any other questions, Nilesh? There was some other question.
Why previous 6 miscarriages?
Yeah,
What
she was aware. Yeah, you answered, Nilesh.
They had done a detailed analysis. Even in this pregnancy also, they had done a chromosomal microarray of the fetus. It was normal.
So there was no identified cause, if I remember correctly.
Yes.
And they thoroughly evaluated. And yeah. And there was no anomalies in the previous, but they were not even that level, but not that they know. Why need for prolonged respiratory support? Yeah. Do you want to answer, Nilesh? And
Sorry.
So bear in mind, this baby had a suboptimal airway, and that would have caused recurrent chronic clogging of the secretions, and needed parenchymal changes as well. So that could explain. But apart from that, we don't think, and also this 36 weeker. So 36 weeker, not quite term. So would explain, and needing tracheostomy itself can cause issues to your lung parenchyma, because that itself can cause and again bear in mind it's a suboptimal, and there was a recurrent collapse consolidation of the right lobe. So that would have led to chronic lung disease. Chronic lung disease is typically described with the extreme preterm, but it can happen with any prolonged respiratory illness. Nalli sir? That is there. So, and any other questions? So one more question, is it? I can see Alimelu madam in the. Ma'am, do you have a comment? Dr. Pratima is there from Delhi. I can see anything you want to comment, Dr. Pratima? I'm just seeing the names I know. Almelu ma'am, anything you want to comment, ma'am?
No, good evening. Actually, I just had one doubt. It was an excellent case, and the management was really good. So the only thing is, did you all try LMA before, in the...
No, ma'am, this airway was completely blocked, ma'am.
Okay.
So there was I don't think we would have, because as you could see that rigid bronchoscopy, it was completely distorted airway. there was no, but still we had a plan A, which is initially video laryngoscopy. Second was rigid bronchoscopy. Third was tracheostomy. And also one of the things we were aware that the anesthetist can't give the placental circulation forever. So we need to be brisk as much as possible. So thankfully, they could give us 11 minutes of placental circulation, and luckily, and with the efficient plan. And one of the risks for these mother is PPH, because they need to keep the moment the placenta, the moment the uterus contact, the placenta will get separated. So that's why they need to maintain this uterus by infusing the volume of the uterus by infusing the warm saline, but that causes the risk of PPH for mother as the baby comes out. So luckily that didn't happen. But coming back to your question, madam, there was no hope because completely it was obstructed.
Okay.
Nandi sir?
So
Nilesh?
there are two questions, sir. One is, what was the reason for recurrent right upper lobe collapse?
Okay. So do you want to answer? We already answered, but you can.
Yes, sir. And
Yeah.
here also the person asking the question is also given the answer. It was selective right bronchus. The tracheostomy tube was low lying and it was more towards the right bronchus, which probably was causing the frequent right lobe collapse.
So it was so this is the emergency tracheostomy of the as much space as they could find. So and in ideally it should be in the midline, relatively high up. So that was the reason where we were trying to balance it not to go too low, not to come out. It did come out a couple of times, and where we rescued. And the second question, facial nerve palsy is improving, definitely improving. Whether one of the, but again, this I don't know why this happened, but it is improving. So left, yeah, eventation is completely improved, and facial palsy is improving. Maybe one of the branch, whether
probably at the time of delivery there could have been some possible injury.
So, but it is much better now. I mean, ideally we could have showed the videos. Sorry, we don't have a video, and current video, yeah. So anything else, anybody? So what happens now, Nilesh?
There are no further questions, then I think
we disperse.
Yes,
I just want to see whether Nalli sir wants to comment anything. Nalli sir? Let me call sir once and.
Yes. There's a question if any chemo was given. So, like we discussed, the histology was a grade 1 immature teratoma. So, this is a benign lesion and doesn't require chemo. Had it been grade 3, then chemo or radiation would have been planned later.
Yeah, that's the right answer. Yeah. So, not indicated here. There's a slight recurrence of slight risk of recurrence. So, otherwise, the follow-up is important. Sir, Haya? So, if no further questions, we can conclude, Nilesh?
Yes, sir.
Yeah, thank you very much, Nilesh. Very well presented, and thank you for all the participants who asked the right questions, and thank you for attending on today. Thank you. We'll say bye bye now. Huh?
Yes, sir. Thank you, everybody. Thank you, sir.